Welcome to Season 2 of EdLab, a podcast of the University of Virginia School of Education and Human Development. I'm your host, Audrey Breen.
A lot of people go for help, and they don't necessarily know that there's a specific treatment for their specific issue. Right? And so that's where we kind of think about the quality really has to match what your problem is.
Yep.
And we have a whole range of evidence-based treatments that have been studied and show that they can work, and also that they can be learned by therapists and disseminated and done with high fidelity. And you really want a specific evidence-based treatment when you have a specific problem.
Did you know that some mental health problems are treatable with specific, relatively short-term evidence-based therapies? And if so, how do you know which providers practice these treatments? Today, we are talking with Professor Peter Tuerk, a clinical psychologist who specializes in evidence-based treatments for anxiety spectrum disorders and who serves as director of the University of Virginia School of Education and Human Development's Sheila C. Johnson Center for Clinical Services, a community-facing outpatient and training clinic. In our conversation, Peter will help us differentiate between general mental health care and evidence-based treatments for specific mental health problems, like the anxiety spectrum disorders he specializes in, that include obsessive-compulsive disorder and post-traumatic stress disorder. But according to Tuerk, not enough practitioners are trained in these treatments. As a practicing clinician who directs the clinic where our graduate students are training to become practitioners, Peter will share how the School of Education and Human Development programs are designed to launch new practitioners into the field well-trained in these areas, and discuss his efforts to support the learning of professionals already practicing. Peter, thank you so much for being here today. Welcome. We're so glad you're here.
Thank you. I'm really excited to be here. I appreciate the invitation.
Of course. So before we get started with kind of your areas of expertise, can you tell us a little bit about your journey and how you got here?
Sure. So I ended up leaving college with a degree, not in psychology.
Oh, no way.
And didn't know what I wanted to do. And so I was telling people, oh, I'm going to travel across the country. That seemed to get people sort of off my back. People could put that in a little box.
Yes. Okay.
Right? So I traveled around for a couple years, played music to fill my gas tank, and camped a lot. Ended up working at a halfway house for teens and really enjoying it. And then from there went on to work at one of those wilderness programs that the kids go to when they get adjudicated. Also enjoyed that with no training. And, these programs didn't have a lot of sort of rigorous training or a lot of psychology behind it. But I really enjoyed the work, and that sort of got me on my path towards psychology.
Oh, my gosh. And so can you tell us a little bit about your role here?
Sure. Like most people here, I wear several hats. One is as director of the Sheila Johnson Center, which is an outpatient behavioral health clinic downstairs. We're face the community, and we treat mental health issues, speech language pathology, audiology, and reading. And the other things I do is I do a lot of supervision of our students that are in our degreed programs, and I see clients myself, and I do research on anxiety spectrum disorders.
Cool. So I know that you in particular have a real passion for quality psychotherapy. Can you tell us what that means and why that matters?
Yeah, absolutely. So when you think about going to see a psychologist, well, what do you think about when you think about going to see a psychologist?
I think about either having a particular stressful time in your life, or you've, just start experiencing something that's relatively limited and stressful, and you need help processing that. I don't know if that's.
Yeah, I think that's really fair, and that's how a lot of people use psychologists and mental health professionals in general, social workers, counselors, sort of everybody under that umbrella. And so when we think about your question of quality therapy, it really depends what you're going for, right? Because many therapists, I would say the majority of therapists, are well-trained people, and when you hit a hard spot in your life, that you maybe need help adjusting to or some perspective, I think going to almost any therapist is a good idea. And we know from Consumer Reports that therapy is one of the highest rated products in the world. People really enjoy being able to get perspective on themselves. And it really doesn't matter that report made it very clear that people just really like the product. But when we think about more specific problems that many people have, whether it's post-traumatic stress disorder or obsessive-compulsive disorder, or maybe our kids have selective mutism, or things like that, trichotillomania, where they're pulling their hair out, you really want to be thinking about specialized care. And this is where it can get tricky for families because the messaging is unclear. And so a lot of people go for help, and they don't necessarily know that there's a specific treatment for their specific issue. Right? And so that's where we kind of think about the quality really has to match what your problem is. And we have a whole range of evidence-based treatments that have been studied and show that they can work, and also that they can be learned by therapists and disseminated and done with high fidelity. And you really want a specific evidence-based treatment when you have a specific problem that is addressed by one.
Yeah. So let's say a child would come in and you would ultimately diagnose them with OCD. What would that look like? What are some things that the parents might be seeing? And then how would they figure out to find, like, how would they find you or someone who had particular expertise in that area?
Yeah, so OCD is an interesting one because when most people think about OCD, what do you think about?
The tapping or the counting.
Counting, tapping, maybe washing hands. Yeah. And really the disorder can be about almost any content. You know, if we get these unwanted thoughts, these scary thoughts or anxious thoughts, and we do something to mitigate that feeling, whether it's counting or washing our hands. But the thoughts could be things like, what if I leave my book bag here and somebody trips over it and dies, right? Or I get a random thought of hurting somebody by accident, and then that thought's haunting me, and then I develop some ritual, right? So OCD can really be many different things. And we know that our kids are kind of in this loop when we're noticing sort of these patterns, these rituals happening, or a lot of times kids are asking parents for a lot of reassurance, right? Is this okay? I thought this, is that okay? And things like that. And so we really encourage people to come in and get an evaluation, because it could just be regular anxiety or it could be OCD. And so with OCD in particular, we know that the treatment called exposure with response prevention is a gold standard treatment. Unfortunately, it's not a treatment that most therapists have access to learning how to do. And so it's also, what we do is not rocket science. It takes skill, right? And it takes learning like everything else, right? So most therapists can end up doing these therapies if they're exposed to them and if they get the training in them. But I think that's what we're missing a lot.
Interesting.
So it is, it's almost like winning the lottery in some communities to actually be able to find a psychologist or a social worker or a counselor that knows how to do an evidence-based treatment like exposure with response prevention.
One of the things we've talked a lot about is the increased mental health needs for adolescents and teenagers. Are you seeing that from your perspective?
Yeah, I mean, I think so. I think it doesn't take an expert to sort of like buy into the idea that we might be in a mental health crisis. Right? And part of that is that there's this idea that there's not a lot of providers out there, and which is true. That the need far outpaces providers. Almost everybody has a wait list. But I think one of the issues behind that makes that particularly troublesome is that we actually have a lot of providers in this area. And most areas have a fair amount of providers. And we need more throughput, right? So providers often end up seeing people for long periods of time. Sometimes years. Right. And when we're thinking about solving a specific mental health diagnosis with a specific treatment, it's not that kind of model, right? We see people for maybe 12 to 20 sessions.
Interesting.
And we go really hard on that issue and give them the skills and help them get over the hump. And in the majority of our cases, the diagnosis remits, so they feel a lot better. And then, the chair is opened up for the next person.
Oh, that's so interesting.
Yeah.
So we've talked about this uptick in mental health. As parents are trying to negotiate what their kid might need, how do they know when it is time for external help and to reach out to a clinic?
Yeah, it's a great question. And it's hard because as a parent myself, I know that kids are moving targets. And so sometimes the kid's hitting a rough spot and maybe they'll just get, outgrow it or, get a new friend and start feeling better, things like that. And I would say, though, that there's relatively little risk in going and just getting an assessment. So you don't have to commit. But if you notice that your kiddo is doing repetitious behaviors or it seems more anxious or scared than usual or is avoiding school or is, having some change in behavior, there's relatively small commitment to make one appointment with somebody to kind of check under the hood and see.
Right.
Because a lot of times by the time folks get to us, many months have gone by, and sometimes that's just a matter of trying to find the right therapist.
Right.
But sometimes it's also a matter of sort of, I didn't know what was going on, which is reasonable. We can't all be experts in everything.
Right.
So I would have a fairly low threshold as a parent to avail myself of assessment services.
Yeah.
And even, you can go online. We're revamping our website at the Sheila Johnson Center in the coming months to have a section that just educates people about different issues and base rates and treatments for disorders and things to look for with your kiddos.
That's great.
Yeah.
You asked me earlier what I think of when I think of this kind of care, but do you think the general population understands this care as that sort of short-term need, or are more people coming in and thinking, I need like almost a counselor on retainer or, this sort of psychotherapy on retainer that's just going to be with me for the, foreseeable future?
Yeah. I mean, I think that when most people think about going to therapy, they think about getting support. They think about getting things off their chest.
Yeah.
They think about getting some perspective, getting somebody to bounce ideas off of. And all that's really important. But that's not really the crux of actually digging in and doing the work to overcome a specific diagnosis. That's more about specific therapeutic techniques to teach people how to overcome their fears and practice. And there's a lot of practice involved. There's a lot of homework involved. And so a lot of evidence-based treatments really are about helping people learn the skills and then helping them be held accountable for practicing the skills in very specific ways outside of therapy, or implementing behavioral reinforcements with their children. And so it's a lot about really understanding people and what they're coming in for, connecting with them, helping them believe in themselves, believing that they can make the change, and then knowing how to teach them how to make that change.
Gosh, that feels really empowering. And there's some agency, it seems, in all of the parties to, overcome some of these things that I imagine sometimes feel almost insurmountable.
Yeah, absolutely. I mean, I think about it a lot as empowering work. And that's really, I think, what drives me. It's almost addictive when you see you can be part of a positive change in the world. With things being tough in a lot of different spheres right now, in general, it feels really great to be able to be part of solutions, small and large. And I think one of the things that's confusing for the field, for the research field, and for people in general, is that, like I was saying, going to see somebody is great.
Yeah.
And there's nothing wrong with what you're saying, having a psychologist or a therapist on retainer.
Yeah.
I think that's really a wonderful thing to do if you can afford it and if there's room for that in your life. And one of the things that confuses people is that because that has an effect, right? We measure treatment outcomes and effect sizes.
Yeah.
It's one measure we use. And because there's sort of an effect that's associated with what we call the nonspecific factors of treatment, that warmth, positive regard, empathy, perspective taking, people can feel better, and they most often do.
Yeah.
They feel better, maybe about a half standard deviation to get a little eggheady on you from, when we measure our outcomes.
Yeah.
And we kind of think about they get like an improvement
Yep.
that's measurable and replicable, and people feel good about it.
Yeah.
And the issue with that is that oftentimes that improvement will go away when they stop seeing the therapist, because it's a support system. It's not actually learning new skills or,
interesting.
And so when we talk about evidence-based treatments for specific diagnoses, we're typically looking at effect sizes that are 2 or 3 or 4 times larger than that.
Oh, wow.
Real life-changing things. Like, I used to not be able to go and spend a night at a friend's house, and now I can. I used to not be able to go to class, and now I can. I used to spend 6 hours in the bathroom every day, and now I do it like normally.
Yeah.
Just really life-changing things. And that's why we want to kind of really focus back on what do you need help for, and what kind of therapy should you be in the market for.
Right. How does a person know the answer to that question themselves?
It's hard. I mean, especially in an information age where there's so much information out there. A lot of it's good, a lot of it's not so good. But I think that, you can Google.
Yep.
And you can look at reputable sites like APA or ADAA, American Disorders and Anxiety Association of America, things like that, and sort of like see, what is this a problem I have that there's a treatment for? Because we don't have evidence-based treatments for everything.
Right.
And what's great is that, if I'm having a hard time adjusting to a new setting or something like that, we don't have an evidence-based treatment for that.
Right.
But if you go to a provider that's an evidence-based provider, they know a lot of skills and tricks, and they can sort of customize something for you.
Right.
Or maybe you don't need that. Maybe you want somebody just to listen to you, and you have those really good skills. And maybe somebody's been doing this for a really long time, and they really understand this population, and they just need to get that support. So you really want to get a good evaluation.
Yeah. Okay.
And, one thing that you also, I think this goes, even in supportive care, you want a therapist that challenges you, that is challenging you and holding you accountable to make changes outside of the therapy session.
Interesting.
Right? Because when people go to see somebody for help, there's an issue.
Yeah.
Right? And so all solutions involve change.
Right.
And all change is hard.
Yep.
Change means conflict. Change means getting out of your comfort zone. And so if you're not being challenged to get out of your comfort zone, that's one indication that maybe you enjoy the therapy you're in. Maybe it does help you cope. But if you're not quite attaining the levels that you want to get to, that's when you want to think, oh, wait, maybe I should get to something that's going to challenge me in a different way.
Right. That's really helpful. So in that sort of spectrum of work that you're doing, you've mentioned PTSD a couple of times in our conversation. Can you talk a little bit about what that actually is? I feel like, and I'm probably guilty of this too, like, claiming PTSD, I feel like it's a very vernacular term. But what is it exactly? Yeah,
PTSD, post-traumatic stress disorder, it's really often misunderstood by our culture, by many in the medical professions. And I think it's because it has the word stress in it. So it's really reasonable and logical to assume that whenever anybody's having a stressful time adjusting after a life-changing traumatic event, that they have PTSD. I mean, Audrey, that's just logical.
That's in the name. Yes.
Yeah. But actually the disorder is much more specific than that.
Oh.
Many things can happen to somebody after a trauma. Right?
Yeah.
But PTSD is specifically related to a re-experiencing of the event, arousal, and avoidance.
Okay.
And so typically people get re-experiencing symptoms in the form of vivid nightmares or intrusive memories of a traumatic event, or they're easily cued to feel like they're back in the traumatic event.
Understood.
And that in turn causes immediate physiological and emotional arousal and anxiety, stress, maybe guilt. And that in turn makes us want to push it away. So we actively push away the memories and we avoid situations that make us feel unsafe or how we felt at the time of the trauma. And the avoidance is absolutely understandable. But the avoidance is kind of what gets PTSD launched because it prevents us from actually processing the event.
The experience.
Right. And so, we're really wonderfully adapted, us humans, to process events emotionally. Right. We need to process things emotionally first because we need to know first to be afraid of the bear.
Got it.
It's the evolutionary pressure to keep us safe so we can reproduce.
Okay.
And our brains are physiologically arranged to facilitate this, right? One of the very first things our brain does with incoming information is it stamps an emotion on it.
Huh.
You know? And then we have easy access to that. And so what we want to do is kind of think about the brain as creating these file folders.
Okay.
Right? When you go to a convenience store,
Yep.
you have an idea of what this is going to be like for you, right?
Yeah.
Right? There's going to be a bubble mirror in the back.
Right.
The milk's going to be more expensive. It's going to be next to the beer, right?
That's right.
Right.
Yes. All the things you really need urgently are the farthest from the door.
Exactly. Right. And that's the experience. And the more that your trip to the store matches your file folder for it, the less memorable it is.
Oh.
Right. And the less it matches it, the more it sticks out in your memory, right? So if you go to a convenience store and there's a clown juggling,
right,
that's not normal.
Correct.
Right? That clowns aren't in your convenience store file folder. And so without you even wanting to or knowing that you you start sort of like trying to solve this problem, right? You're flipping through the roll, like, why is this clown here? Why is this clown here?
Huh.
Right? That's your gravity to process. Right? And in PTSD, the processing of something that's new gets prevented because of our avoidance. That's absolutely understandable. See, that's the thing, right? It's
right.
Everybody wants to avoid.
Yeah.
Why would you want to feel bad things?
Right. So this event happened, and I mean, I know maybe I should take us back one step just to say, I think a lot of us think about PTSD as a result of armed conflict, wars or battles or that kind of thing. But it sounds like what you're describing here is this could really happen any place where there is a significant enough diversion from what we think of as a normal occurrence in a particular environment.
Yeah, I think so. But we want to be put a little bit of a point on that.
Yeah.
It's typically only life-threatening events or very traumatic events that get us to a place where we actually experience something completely emotionally new.
I see.
Right. And so without that file folder, I've never felt this, but I've never had this gun pointed at me before. I've never had my bone broken in this way.
Right.
We don't have that file folder. And so, going back to this idea that the clown's juggling, right? You're going to remember that the clown is there.
Right.
And then if something really odd happened, like an example I use all the time is if there's an elephant in the store, right? You don't even know how the elephant can get in there.
Right.
And there's mounds of like things everywhere,
right.
and there's aisles tipped over, and you get your milk, and you ask the cashier, "What's this elephant doing?" And the cashier says, "I don't know." Right. Well, I think we both can agree that's going to stick out.
Right.
Right. And next time you see an elephant or any zoo animal, you're going to think of the store. And next time, it's sort of like a sock sticking out of a drawer. It's unprocessed.
Right.
Now we can process it. We have the capacity to create a file folder for it. And the very big difference between this elephant example and something that can cause PTSD is that the elephant doesn't carry with it the intense emotions of being life-threatened. So we don't avoid thinking about it.
Right.
In fact, the opposite happens, right? You're going to be taking selfies with the elephant.
Yeah.
You're going to be on Facebook with the elephant.
You guys are not going to believe this.
Exactly. Within 30 minutes, everybody in your social network is going to know there's an elephant, right? And through that, you're going to be processing this.
Yes.
Right? And it's likely to go into a folder. There's like crazy things happen in the world sometimes, and I don't know why.
Right.
Right. And so with PTSD, that folder never gets made. And so we want to give people the opportunity not to get it off their chest, right? Not to sort of vent about it, but actually to learn how to approach it and handle their heart pounding or their sweat or intense feelings of guilt at first or whatever it is, long enough for them to habituate enough to start making sense out of it and start processing the details they can create that folder. And once they do, magical things happen.
Really?
Right? So the nightmares go away, the intrusive memories go away, or significantly reduce. And then at the same time, we're helping people, deal with their other things that they've been avoiding in their life, which is maybe not going to the store. Right. So they're starting to process, I can go to the store. Not all stores are dangerous.
Interesting.
And so in the evidence-based treatments that we're referring to, it's really about sort of coaching people. How do I act in a way to get me out of this?
Wow. That's really interesting. This idea that providers can be trained in this work, and really it's making sure that they have access to it. Is that how you ended up in this role?
Yeah, Audrey, that's basically exactly how I was working at the Medical University of South Carolina and at the VA down there, and doing a lot of PTSD work after our large deployments overseas in those wars, and ended up doing national trainings and getting very involved in training other clinicians how to do evidence-based treatment for PTSD.
Yeah.
And through that work, getting grants and other doors opening, ended up training clinicians in community settings, and basically kind of just going around where people had grants for training. And it occurred to me that, as wonderful as that work is and as important it is, the reason we need that work is because there weren't enough programs teaching people how to do evidence-based treatments when they were getting their degrees.
Oh, interesting.
So this position became very attractive to me.
Yeah. Talk a little bit about the way our preparation programs and the Sheila Johnson Center interact or intersect.
Sure, I would love to. So, we have very, very bright students and across several different degrees, clinical degrees. And what we do downstairs is we deploy and serve the community with evidence-based treatments for specific diagnoses. And we teach the students how to do those therapies. And they have wonderful facility with it. Like I said, it's not, anything is easy if you know how to do it and if you practice and if you put in the work. And so we try to craft referral streams downstairs that are aimed at the highest base rate disorders that the community is facing, and also that will give our therapists the evidence-based treatment skills that they need to sort of learn almost any evidence-based treatment when they're done with their training here.
Can you talk a little bit about, obviously connecting our academic preparation programs and a practicing community clinic is one way that these partners come together, but can you talk about what partnerships mean for you and your work?
Yeah, I think that it's really important, as a community-facing center, our outreach is a really important part of what we do. And we develop these referral streams from providers in the community, and then, you have to water those, right? Just like any relationships. And so we're trying to make sure that we're a resource for people in the community. And so when we get a good referral from somebody, we make sure that we go back and thank them for the referral, and, we've got release of information so we can talk to them about how their clients are doing. So we really try to make sure that we're getting back to those sources, whether it's a school system, who we serve a lot of schools, give us a lot of referrals,
right,
or other providers in the area, more general providers that maybe they hit something and they think, oh, this was depression, but actually I think it's OCD or I think it's PTSD. Let me send them to the Sheila Johnson Center for that specialized treatment.
Got it. And I know, just because my office is down the hall from a larger gathering space here at the school, there are some times where we can invite and connect with practicing clinicians to try to increase their capacity with some of these skills. Can you talk about how you and the role that you're in can contribute to that, educating beyond our own students that are here? Absolutely.
So once a year, I do a 3-day workshop for community clinicians, and they get CE credits for it for free. And that's in training in prolonged exposure therapy for post-traumatic stress disorder.
Okay.
Where we watch videos, we go over the theory of treatment, and we do role plays and question and answer and things like that.
Yeah.
And it's a really nice time for the community to come together. And they usually get pretty full pretty quick, which is fun for me.
Right.
And it would be great if we had time to do more of those things. And as I think when we look forward to the next year, some of our upcoming plans is to maybe expand that into, how do you treat OCD, or how do you treat trichotillomania or encopresis, or some of these problems that we are seeing popping up in the schools a lot.
Yeah. So at the Sheila Johnson Center, you guys have a lot going on. Our students are down there. You're working with, obviously, individuals and families that are local. How do you pull all of that off in one place?
I think that it comes down to all the wonderful people that we have downstairs and all the people that were attracted to the program and that we've been able to recruit. Just wonderful, phenomenal clinicians and educators, and just a phenomenal staff. And we have a real sort of mentality of service, right? Yeah. We think about service as serving the academic community, serving our students, serving our patients, serving the faculty in this building. and also serving each other.
Yeah.
And so for me, it's a really great place to be a part of, a very positive culture. And I'm really excited that we're here doing this work.
Yeah, I am too. Okay, one of the question I ask everybody.
Yeah.
If we were having this conversation 10 years from now, what do you hope that we would know then that we don't know now?
Oh, that's a great question. Well, I hope that we would know how to disseminate evidence-based treatments and also value the people that aren't doing evidence-based treatments and help people be educated to know what type of therapist should I go to.
Yes.
Right? Because both are important.
Right.
And so that would be great. And so there's a whole science and dissemination science, and it's muddy and sticky sometimes. It's a hard thing to study in a controlled way. We can study fairly cleanly if I come up with a protocol. How do I do this treatment?
Right.
I can do a randomized controlled trial and see that this treatment works better than that treatment. And now we're talking about, well, how do I get therapists to do this? Or how am I good enough where I can teach them how to do it? It's replicable.
Right.
I would imagine it's sort of a lot of the same things we end up sort of problems we're struggling with curriculum instruction,
Exactly.
right? How do we get a quality curriculum out the door?
Yep.
And in a package that people actually want to do it and can do it.
Yes. And then is done with the fidelity that showed that it was evidence-based to begin with.
Right.
Yeah.
And so a lot of my own research is about using digital technologies in this space, crowdsourcing to sort of teach people evidence-based techniques, and increase accountability and teamwork between therapists and patients, and also among therapists. Like, we come up with a good protocol, we want to be able to share it and disseminate it quickly and easily.
Yeah. That's exciting.
Yeah.
Well, thank you so much for your time, Peter. It's been super helpful just to hear about your work, and I'm really grateful that you shared it with us. Thank you.
Thank you. I really appreciate it.
EdLab is a production of the University of Virginia School of Education and Human Development and WTJU 91.1 FM. EdLab is produced and hosted by Audrey Breen with support from Mary Garner McGee and Sage Tongwe. Our music is Palms Down by Blue Dot Sessions. You can subscribe to EdLab wherever you get your favorite podcasts.